Good afternoon, everyone. It is noon, so we're going to get started. We want to welcome you to Wednesday Wellness, a free live educational series by Trinity Health. We're thrilled to have you with us as we dive into back pain breakthroughs, evidence-based approaches that actually work. Before we get started, here are a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A chat feature at the bottom of your screen. Questions will be addressed at the end of the presentation. Lastly, today's webinar is being recorded and a link to the video will be sent to you via email. And without further ado, I am pleased to introduce Dr. Robert Leinoff, a neurosurgeon with Trinity Health Medical Group.
Good afternoon. Very happy to give this talk today. This is something that's very important and very common in what I see in my clinic, and that is back pain. What are some breakthroughs and what are some evidence-based approaches that actually work? So who am I and why am I giving this talk? My name is Rob Leinoff. I'm a board-certified neurosurgeon. I've been in practice now outside of training for the past 7+ years. I'm a general neurosurgeon. However, I do have a subspecialization in spine surgery. I try and do as much minimally invasive spine surgery approaches as possible. However, a big portion of my practice is also revision and complex spine surgery. And also relevant to this talk, I do some pain modulation procedures. So what we're going to talk about today is understanding the major types of back pain, and something that's really not talked about enough in Western culture, Western medicine, which is actually really important, is the emotional component of pain, and also how sleep affects chronic pain. And then after that, we'll get into some evidence-based treatment approaches, as well as some practical decision-making framework. So in order to proceed to the treatment approaches, we really have to understand what is the scope and what are the types of back pain. Approximately 80% of adults experience low back pain at some point in time. Now, we're not talking about necessarily, you go to the grocery store, you carry too many bags in, your back hurts, you go to the gym, you're sore. This is really clinically significant back pain. So 4 out of 5 of us will experience that in our lifetime. It is a leading cause of disability worldwide, and the annual direct medical costs exceed $90 billion in the United States. 90 billion, that's huge. So it's vitally important. And again, it's really one of the most common things I see in my clinic. And the first thing I really need to do to help some of our patients is to understand what the type of pain they're dealing with is. Back pain is a broad term. There's really subsets of back pain. And once we understand what it is, we can more effectively treat it. Some of the types are myofascial pain, mechanical back pain, facet joint pain, discogenic pain. And then one that is really considered separate from, traditional low back pain, which is neuropathic pain. This is the nerve pain. This is the pain that's going down the arms or the legs. This is treated differently. And really, as surgeons, we're actually more successful at treating neuropathic pain, at least a little more easier than we are back pain. So it's a little bit unique because we're really going to hit that back pain on this talk, but it is important to cover a little bit here. And the big thing here is each type requires different diagnostic and treatment approaches. So we got to understand what we're dealing with here. So when I have these visits, one of my first goals is clarifying as early in the visit as possible the type of pain, and that really allows me to focus on it, really key in on what the pain generator is, and then we can spend more time on treatment options. And the other thing to keep in mind is, patients often have multiple types of pain. Multiple types of back pain. They might have neuropathic pain on top of it. And so really the first question I ask is, what bothers you the most? Because that's the thing I'd like to help you with. And I'll ask that on every visit. What bothers you the most on the last visit in February might not be the thing that bothers you the most on this visit today. So it's always key to ask that question. So let's get into some of the types of back pain here. Myofascial pain is pain that originates from the muscles and the surrounding connective tissues. Now, we're not talking about the spine, we're not talking about joints, we're not talking about nerves. we're talking about, or I should say the bones in the spine, we're talking about the surrounding muscles and connective tissues. There's a prevalence of 64% of myofascial pain in patients with chronic back pain. So if you come in with chronic back pain, there's a 64% chance at least part of it is due to myofascial pain. And this is often characterized by trigger points and referred pain patterns. What trigger points are, if, let's say somebody comes in with back pain and I'm examining their back and in the muscles, they have a nodule that where I put my finger on, it's incredibly painful. It's like, ow, yes, that's a spot. Please fix that. That would be a trigger point, a sign of myofascial pain. And that picture there is actually showing a trigger point injection where in that nodule you'll inject a local anesthetic and a steroid, which can be greatly effective in treating myofascial pains. Mechanical back pain is the most common type of pain, typically seen in at least 70% of cases of patients that come in with low back pain. This results from abnormal stress on muscles, ligaments. And the key things we get here in terms of the history, it's often position dependent or movement related. And it really does improve with rest. And then it does worsen with activity. So those are kind of the things we're listening to on the exam. This picture here on the left, this is kind of a cool new tool that we have, or a recent tool, I should say, when we're doing surgeries. So this patient is getting surgery for back pain. They had several types of back pain. They have mechanical back pain. This bone, L5, at the lower part of their back is slipped forward on top of the sacrum. So there's abnormal stress from the slip. There's not abnormal spinal alignment. Now, they also have facet pain because the facets are moving abnormally, and they also had neuropathic pain. The neat thing about this device here is when we do the surgery, I take the disc out and we lock the device into L5 with this screw here, and we lock the device into S1, and you can see it's offset, and it's got a little drive in the center here. So we put some bone graft in there, and then I have a driver that, if you see on this picture on the right, what it does is it reduces the slip. So it brings L5 back on top of S1. So this is, kind of a unique new device that we have. So we do the fusion. It decompresses the nerve pain by reducing the slip. It addresses the joint pain because it takes the motion out of the joint, and then the abnormal stress on muscles and ligaments above and below due to the abnormal spinal alignment is treated as well. So it treats some of the mechanical back pain. Facet joint pain is quite common, seen in at least 15 to 40% of chronic back pain cases. I think it's probably on the higher end of that normal typically. This pain is typically worse with extension and rotation and can often be bilateral, and there's a common referral pattern to the buttocks. So again, we're just kind of listening to things about this patient's history to clue us into where the pain is. The hallmark of diagnosing this outside of the exam and history is our diagnostic blocks, what we call medial branch blocks, to confirm the diagnosis. And so if you look at this picture on the left here, the facet joints are those joints which are on either side of the spine. And so anytime you rotate, one of the facet surfaces are going to be closing down, one is going to be opening up. And when you extend back, you close down the joint space. So if it's a painful arthritic joint and you're closing down the joint space, that will elicit pain. Medial branch is a nerve that transmits pain from the joint to your brain, lets you know that you have a pain. So if you block that nerve and the nerve goes away, that is a diagnostic test for that specific joint. Discogenic pain is seen in chronic low back pain patients. This is often characterized by axial pain that worsens with sitting. And, so the patient says they'll sit down. I have this deep midline pain. I can't put my finger on it. It's not one side to the other like a facet joint. It's just really midline and deep. And so that's kind of the hallmark here. Now, the key thing here is the disc degeneration seen on imaging often does not correlate with the pain. I can't tell you how many times a patient comes in with back pain. They have an MRI with a read that says they have a disc bulge, an annular tear. But when we go through the exam and history, none of the pain correlates with that exam finding. So that's one of the things that, sometimes gets a little frustrating for patients, when they come in and say, hey, I got this disc bulge, fix my pain. And I kind of, say, well, let's not talk about the MRI yet. Let's figure out what's going on. And that is because, what we see on the imaging often does not correlate with the pain. Disc herniations can present initially with back pain only. In fact, a lot of times the ways disc herniations present, somebody's at the gym, they have really bad back pain that comes on, and then all of a sudden, a couple hours later, or even a day or two later, they start to have the leg pain, and then the leg pain typically comes predominant. Disc herniations can spontaneous resorb in about 66% of cases within 6 months. And really, when we talk about surgery for disc herniations and radiculopathy, the leg pain, the arm pain, 80% of patients get better without any operations. There are different types of imaging findings we see. If you look on the left there, that correspond with potential discogenic pain. What we look for are called modic changes on the MRI, and they correspond to certain types of changes in the bone. For example, this picture on the left with the red end plates there, that is an inflammatory change in the bone that will often be painful. Then you can have fatty infiltration in the bone, that is not as commonly as painful. And the same thing here with sclerotic or increased density of the cortical bone. So those findings are seen on MRI, and we pay attention to those differences because some are more likely than others to be painful. And then neuropathic pain. Again, as kind of as I talked about it in the first part of this talk, this is really treated differently. And because of that, it's really one of the first questions I ask or type in the initial questions is I try to elicit, do we have a neuropathic pain component? And that's characterized by shooting pain, burning pain, electric pain, toothache pain, and it will often follow what we call a dermatomal pattern. So that's kind of these these patterns here that we see on this image on the left. And so, I'll ask a patient like, well, if you have that electric pain, can you draw a line where it is? And what I'm trying to elicit is what nerve does that match? And so that's an important thing because, again, those are different treatment paradigms. Neuropathic pain is seen in 20 to 35% of patients with chronic back pain. And so those are really the types of pain. Now, this part of the talk here really, this should be an entire talk on its own. It is that important. And in Western medicine, Western culture, it's really not talked about enough. And hopefully I can just, relay here a little bit how important this is. And that is a pain-emotion connection. And so we all, through our experiences, we have emotional and cognitive filters that we develop over time. And our pain is processed through those filters. And so that's really important because we can change those filters. And what we see, and also in the pain-emotion connection, is in chronic back pain, depression is 3 to 4 times more common in those patients. And also what we see is anxiety amplifies pain perception and reduces its pain tolerance. And so there's a cycle. Let's say I go, to the gym, I have acute back pain. You're playing with your grandkids, you develop back pain, and all of a sudden you have to reduce your activity. You stop working out. You might have to take your time off from gym. You're laying in bed more often than not. You're not doing any gardening, and that's over a couple weeks. So you have reduced activity, which leads to deconditioning. And then with the deconditioning, you don't want this to happen again. You're afraid if you start doing things that the back pain is going to come on. So you might say, all right, I'm not going to exercise anymore. I'm not going to garden anymore. And you have fear and avoidance of the things that you enjoy in life. Well, then you're going to have negative thoughts. Your filters have this negative hue, this negative point of view. And then this leads to depression and anxiety. And as a result, as we discussed, when you have anxiety, you have increased pain sensitivity. Well, if you have increased pain sensitivity, this is going to lead to more pain and the cycle starts over. So you really have to break this cycle. It's very, very important. And then there's something called pain catastrophizing. And so what pain catastrophizing is if you take 2 patients, they both have the exact same injury. One patient catastrophizes, one does not. The one who catastrophizes, even though they have the same chemical inflammatory injury, their pain is going to feel 31% worse just because of the catastrophizing. They're ruminating on it. They're magnifying the pain. They have feelings of helplessness. And you can actually see this on functional MRI, this different brain activation patterns. And the key thing here is it's a strong predictor of poor treatment outcomes. So with those 2 patients, We can offer the exact same treatment for the exact same injury, and one patient is going to do much better than the one who catastrophizes. So let's treat the catastrophication in addition to treating the chemical mechanical component of the pain. Sleep is huge, not only in chronic pain, really in overall life. Again, I wish we talked about this more in Western medicine. And in some instances, we do. 50 to 80% of chronic pain patients report sleep disturbances, and there's a bidirectional relationship. So, obviously pain will disrupt sleep, but then poor sleep will make pain feel worse. And so sleep disruption reduces the pain thresholds. And what we also see is that sleep loss increases inflammatory markers. Okay. I was listening to a recent talk from a pain doctor from a tertiary center. They see the really tough cases in Canada. And he said the first thing he does with any chronic pain patient is treats their sleep. And it was very nice to hear that because, I really do believe it's such an important thing. And so there are some sleep interventions for pain patients. And one of the hallmarks is cognitive behavioral therapy for insomnia, CBTI. And this is found to reduce pain severity by 30%. That's pretty significant. Most patients who come in and say, if I can get 30% better, that's a big start to me overall getting better. What you need to do, there's the cognitive behavioral therapy. We need to work on having consistent sleep-wake scheduling, sleep hygiene practices. And one of the key things, in this day and age with our cell phones, our tablets, you really need to limit screen time before bed. The wavelengths of light that those screens emit mimic daytime. So your circadian rhythm, your brain thinks it's daytime, so you're not going to be able to get quality sleep. There's nice restorative deep sleeps. That's going to be thrown off. So maybe you get some sleep, but it will be less quality, and it probably delays and limits the amount of sleep that you get. So that's very important. Ideally, you're going to limit screen time to 2 hours before you want to go to bed, at a minimum 1 hour. And if you do have pain, you don't want the pain to interrupt sleep, so manage it you best you can prior to going to sleep. And really, I think that could be an entire talk in and of itself. And hopefully, again, this is more talked about, as time goes on. So I think that's vitally important. Here, what we'll talk about going forward is a little bit more of the other treatment approaches directly addressing the physical chemical components of pain. First steps outside of activity modification are medications. Physical therapy is important. Again, we kind of talked about treating sleep and the emotional component very briefly. Injections, and then spinal surgery, spinal cord stimulators, and the last thing is multifidus stimulation. So medications, kind of the first line treatments are non-steroidal anti-inflammatory medications. That's the over-the-counter ibuprofen, naproxen. These reduce pain scores by 8 to 12 points on a 100-point scale, so about 8 to 12%. Doesn't sound like a lot. The reality is there are a lot of patients who get significantly more relief at that. However, there are patients that don't get much relief at all, and this is good for acute low back pain. So typically, short-term use is recommended because there are side effects such as gastrointestinal, cardiovascular, renal risks. Patients with history of heart disease, stroke, you probably want to limit those medications. There are really patients out there with chronic diffuse arthritis that really take these long term, and they get good relief with them. Muscle relaxants are another acute pain medication that are commonly used. A little bit variable response with these. Some people get great response. Typically, they provide effectiveness for the first 6 weeks of an acute pain event. However, I do have patients that sometimes say they get some lasting benefit from these. And beyond the NSAIDs and the muscle relaxers, there are two anticonvulsants commonly used for neuropathic pain, that nerve pain component, and those are gabapentin and pregabalin. They do not work for everybody, but again, if the patient has a strong neuropathic or nerve pain component, it makes a lot of sense to try these medications. You start at a low dose and you ramp up as the patient tolerates and gets benefit. Two antidepressants, duloxetine and amitriptyline, have shown to be effective for chronic pain, probably because they are treating some of that emotional component of pain that's out of whack. In terms of the opioids, there's limited evidence for long-term use. I mean, look, I get it. There, when you do have patients that come in and they say, their dose of opiate kind of gets them through life a little bit. This has been a big talk over the past, half decade due to the epidemic and overuse. And one of the reasons, we probably want to limit this is really when we look at the studies, there's no significant difference between opioids and non-opioid medications at 12 months. So if these addictive medications that lose effectiveness with time are not superior, then they're probably not worth the risk. And again, I understand there's some folks who this is a good medication for them, but I wonder if we went back in time and we had really found a better treatment for them in the past, would they be as equally as good or if not better off than they are at this point in time had they not gotten on the chronic opioids? Now, this medication here, again, we're going to talking about breakthroughs. I do not have personal experience with this medication's use. This is a new approval, suzetrigine Journavx. This is a newly approved pain medication with a unique mechanism of action, which we've not really had one of those in probably at least 20 years. So it's kind of a neat thing. I've already had some patients asking about it. I just don't have good experience with it. This medication works on the peripheral nervous system receptors specific to pain pathways. So it's a little unique when you compare it to nonsteroidal anti-inflammatories, which have a little bit more of a general effect. This one is specific to pain pathways. And the key thing here is the studies have shown it is significantly more effective than placebo, specifically placebo, in acute post-surgical pain. Better than placebo in acute post-surgical pain. However, they're not as effective as hydrocodone acetaminophen combo. Okay, so this is not like this is some magic bullet here. It is a good tool, it looks like, at least for acute pain. It is under investigation for chronic pain use. So we don't really have good data on that yet. So I don't think I could offer this as a medication for somebody with chronic pain, at least not yet. Maybe as I learn more. But one thing here that was a little discouraging in terms of my clinic is an earlier study showed that it was no better than placebo when treating lumbosacral radiculopathy. So that is the nerve pain in the arms or the legs. Physical therapy. Physical therapy is a great tool. A lot of patients get great response to this. Some patients don't have good response. Some patients, it makes them feel worse. It makes a lot of sense to try. It can be very good in treating the acute pain, but it is also very effective in reducing recurrence of pain, up to 40%. And the reason is it's going to focus on core strengthening, flexibility, and posture. If you look at this diagram on the left here, we've got one patient with pretty bad posture. We got another patient with great posture, spine is in balance. This patient with the poor posture is much more likely to have recurrent issues with pain. The patient on the right, much less likely. Their spine is in balance. There's less stress on the connective tissues, the ligaments, the muscles, the joints. So it is important. And oftentimes when I see a patient with poor posture, deconditioning, and balance, once their pain is treated, I often say, hey, this is a good time to get you into therapy to build your spinal balance, work on your posture. Multimodal approaches showed greater long-term benefits. And really, when we're doing physical therapy, the important thing here is it's tailored to specific pain generators. Each patient is a little bit different. And so that's part of the job of the therapist is where are the imbalances here? Where is the pain? How can I make this patient better? So I think it is important. And, one of the things I get when patients come in is, they might say, I get enough physical therapy at work, or, I chop wood and move hay bales, so I don't need physical therapy. Well, the reality is, yes, you're probably fit. You're probably very effective at that one motion, But my guess is your spine is out of balance because that is a repetitive motion. There are probably other muscles that are underworked, and that imbalance is what's going to get you into trouble and might be why you come into my office in the first place. So physical therapy does work, not for everybody. Again, if this is making you feel worse, we stop it, we try and treat it, and then it might make sense in the future to return to it to reduce further injury or recurrence of your pain. I'm not going to get too much into this. There's really just multiple approaches to physical therapy. And again, kind of getting into this thing that's not really talked about much in Western medicine, but is actually very effective. Meditation, breath work. Mindfulness meditation reduces pain intensity by 27% and emotional aspects of pain by up to 44%. That's pretty darn significant. Breathwork techniques activate the parasympathetic nervous system. So this is the opposite of your stress response. Instead of fight, flight, stress, anxiety, this brings all that down. Regular practice actually shows you change the structure in the brain in the pain processing regions by doing this. And an 8-week mindfulness program showed clinically significant improvement in pain and function. So it's really a great tool. And it can be as simple, if you look at this on the left, breathe 4 seconds in, 8 seconds out. You do that for 20 cycles. And you do that, once a day, and you get benefit. You are treating your pain actively in a very effective way. Now, maybe things are bad where you can't go to the gym. You're limiting your activities, and so you're spending a little bit more time on the couch or in a chair. This is your time to do it, to actively help yourself, and it is very effective. Another thing I commonly get asked about is our stem cells and platelet-rich plasma. Platelet-rich plasma is a concentrate of growth factors from the patient's own blood. And then you have stem cells, which are derived from patient bone marrow or adipose fatty tissue. The proposed mechanisms here are anti-inflammatory, reduce that type of pain, immunomodulatory, and potentially regenerative. The problem here is the evidence is really moderate quality, and the results are inconsistent at best. So yeah, they may or may not work. I mean, if you could prove they're regenerative, I think that's potentially a huge thing. If you can improve these technologies to be regenerative, that'd be very powerful. But the reality is the data is not there. Now, I'm not going to tell any of my patients out of it. The reality is insurance is probably not going to pay for it. But if you think it might be of some benefit for you, I'm not going to talk you out of it, but I'm not going to recommend it either. But I do get asked about it, so I did want to bring that up here. In terms of some of the regular treatments that we have, getting slightly more aggressive, invasive injections, epidural steroid injections. These provide short-term relief in 75% of patients with radicular pain. And they're actually most effective for those with acute radicular pain from disc herniation, so that leg or arm pain. There's limited evidence for long-term benefit in degenerative spinal stenosis, so just kind of that overgrowth pressing on nerves. Different ways to get the medication where it needs to go, whether it's interlaminar, transforaminal caudal. The key here is if you look at this image, you need to get the medication in the epidural space. And this is actually not the best image because the spinal cord shouldn't be here, but individual nerves. So you have individual nerves going down this channel in the spine, and then you have a covering, the dura. An epidural is outside the covering. So this medication we put outside the covering decreases the inflammation there. Another type of injection, and this is more for the facet pain, so a subtype of the back pain. These are medial branch blocks, and if you do well with those radiofrequency ablations. And what we find is that if we think the patient has facet-mediated or joint pain, and we try a medial branch block, medial branch is the nerve, again, that sends the pain signal from that joint to the brain, so you register that joint as painful. If we block that nerve, and the patient has 80% pain relief, then it is highly predictive of success with a radiofrequency ablation. So that's an important test. Now, you may not hit 80%, And I still think there are a subset of patients, if you're too picky, where we maybe don't hit that threshold, and we can maybe miss some patients that would potentially get success for the radiofrequency ablation. That's where medicine becomes a bit of artwork, and we miss some folks if we stick too hard and fast to the numbers. So just something to keep in mind. Data shows that radiofrequency ablation provides greater than 6 months of relief. So the block is a local anesthetic. It's only going to give you a few hours, up to a day or so of relief. But the ablation is where you're going to start getting relief that should be around 6 months or greater. And the key thing here is they can be repeated. And some of the best studies show that with the ablation, that hit that criteria of 80%, 87% of patients that get the ablation have at least 60% pain relief. So that's pretty powerful. In a smaller subset, 60% of the patients that get the ablation, they will have at least 90% relief, which is durable throughout at least a year. And again, that can be repeated. Oftentimes, patients will repeat it till the blocks stop working, and then you have to look for other tools. Again, patient selection, exam, history, blocks is crucial for success here. This is a newer technology, basivertebral nerve ablation. This is more for that vertebral end plate. Remember that bright red end plate? Those types of changes, some would say for discogenic pain. This treatment, this targets the basivertebral nerve within the vertebral body. So that's going to be this nerve here, and you can see the red indicating some inflammation. And so if we kill this nerve off here, that you don't feel the pain to the segment. It is a minimally invasive ablation, again, a radiofrequency ablation. And what those do specifically is with those waves, they create heat, which kill the nerve. And there's 75% success rate in significantly reducing pain if you can, with this treatment, if they have this type of pain. Now, the difference here is these results are actually durable at 5 years, which is even better, right? Obviously. The thought is because that medial branch nerve for the facet pain, the nerve pathways are a little more robust, so sometimes they regenerate, where here this is a less robust nerve pathway, so it tends not to regenerate, and so the results are much more durable. Again, this is a smaller subset of patients, so this sounds great. You might get you really excited, but if you don't have discogenic pain, it's not going to work for you, or vertebrogenic pain. And then spinal surgery. I think a lot of folks come to my office either like, I want surgery, I want this taken care of, or scared to death that I'm going to tell them they need surgery. The reality is, if you have back pain outside of arm or leg symptoms, there's only a small percentage that will actually benefit from spine surgery. Some studies show as little as 1% to 2%. I think it's higher than that. And probably, some of these studies say it's a small percentage because the earliest studies demonstrated no or little benefit when you compare spine surgery to conservative management. However, as I think we've learned more, we've gotten more selective in the patients, there have been better studies, and I think that's only going to continue to improve. So far, some of the best studies, which, in terms of quality, they show a visual analog scale pain improvement of at least 2 points. So that's the 1 to 10 scale of pain. And 75% satisfaction with surgery. Now, 2 points may not seem like a lot. If you go from a pain from 8 to a 6, it is significant. And the reality is, if you're really careful, I think you get much better improvement than 2 points. I'm very selective with it. I do offer it. There's some surgeons who maybe don't offer spine surgery for back pain ever. So I think there's a middle ground here, and I really do believe that. There are some real clear indications for spine surgery, and there's a common thread you'll see here. Those clear indications are progressive neurologic deficit, weakness, loss of function related to nerve, spinal cord compression, instability threatening neural element compromise. So that would be this patient on the left here. This is a trauma. The patient had disruption of this disc space in the thoracic spine, and they had a fracture through the posterior aspect of the spine. This spine is unstable. Fortunately for this patient, they did not have any weakness or spinal cord injury. So we were able to stabilize this spine, eliminate the risk of spinal cord injury at this level. Cauda-Equina syndrome. Again, this is another nerve compression problem. And then disabling radicular pain despite conservative treatments. These are all clear indications involving nerve, right? not back pain. And so that's where back pain, surgery for back pain is not as common as folks think. So what are the types of surgery we'll do for back pain? Microdiscectomy, yes, you can have back pain with that. Really, you're treating nerve compression more than the back pain. There's 85 to 90% success rate for appropriate candidates. Again, this is more of a nerve surgery. That's why the success rate is so high. Decompression for spinal stenosis. Again, we are talking about nerve compression problem. Then here, fusion for instability. Well, you could say the goal of doing surgery for instability is to protect the nerves, but they can also be quite painful. So that is somewhere where back pain can be effectively treated with surgery. And this is the one here where I think if very careful, these patients can get great benefit from surgery. And these are the patients with segmental pain. So it's not arthritis up and down the spine. They have pain, for example, a lot of degeneration, localized to L4-5. The rest of their spine looks reasonably good. Their exam matches L4-5. And then we have a reliable demonstration of pain. We've tried facet blocks. Every time you get the block, the patient's a lot better. You've done an ablation for a couple of times. And then the third time, the ablation, instead of getting, almost total relief for the first couple of ablations, the last one doesn't work. And the rest of the spine looks reasonable. I think that is a patient that I will offer spine surgery to and will do very well. And they will get better response often than that 2-point improvement in the visual analog scale. So there is a role. Artificial disc replacement in the neck is a little unique for this, different than what I'm talking about here in terms of back or neck pain. That is often for the nerve compression problem. Now, there are artificial discs in the lumbar spine, and the approval for that is more of that discogenic, vertebrogenic back pain. I don't do it. I offer them. It is very rare. This is a very rare patient. I probably do it once every 3 to 5 years. But now that the basivertebral nerve ablation is around, is that the better treatment? It very well could be. So I think, artificial disc replacement for low back pain is a very rare thing, but it is still done. And then when we look at spine surgery, how do we improve our outcomes? And I'll harp on this. We got to find a reliable pain generator. The imaging has to correlate. The exam has to correlate. And if you don't have those 3 things, you probably should not offer it. And there are also, really no other options outside of potentially pain modulation. But again, pain modulation is a little different because you're not actively treating something. You're just kind of turning the volume down on the pain. And really, you have to talk about realistic expectations with these patients. When we're talking about surgery for back pain, again, there are a lot of reasons and often overlapping reasons that a patient will have back pain. And you are going to treat 1 or maybe even 2 segments and treat that pain because you take the motion out of it. I would not promise ever that the patient's going to be 100% better. I think a great goal, if they're getting 80% improvement in the blocks, it's just they stop working, then I'd say, hey, look, our goal here is 75 to 80% improvement in your pain. But, that really is, careful workup, careful discussion. This patient, I showed this image here because this is, again, we're kind of talking about new tools. This is, I've moved to using robotic spine surgery, whether it's my minimally invasive or vision approaches. And this here shows a plan. So the patient will get images and I can plan the surgery prior to them even coming into the surgery suite, coming in prior to the day of surgery. And this is another good example because not only does it show one pain generator, which was obvious, there was another pain generator, which was hiding, but we found with careful discussion and careful examination. This patient had a prior fusion at the base of their lumbar spine. You can see by this metallic plate here. However, the fusion did not fully take. They have pain localized to this segment. Now, if I just looked at that and say, you got pain, well, let's go fix it, and I ignored or I missed, didn't do a careful exam, I would have missed the fact that this patient had a very significant component of sacroiliac pain. But I caught it on the exam. And prior to saying, let's go forward with fixing this problem at L5-S1, I said, look, I don't want you to have this surgery You continue to have pain. Let's try this block. If I'm wrong, you don't respond, we move forward at L5S1. However, if I'm right, and we need to treat this with surgery, that we kind of take care of it all at once, one operation, rather than, getting a surgery, you're only 50% better, you're questioning why you did it. And then I say, well, hey, we should go fix the sacroiliac joint now. Now you're like, I don't know if I want any more surgery. And we potentially missed something very treatable. This person did extremely well. We tried some blocks. We tried a therapeutic injection in the sacroiliac joint. It did not take. With the blocks, they got great relief. It's just the therapeutic injections did not take. So it was a reliable pain generator. We treated both L5S1 and the sacroiliac joints with the robot, and they did extremely well. So realistic expectations, careful examination. Spinal cord stimulation. This is a tool that's been around for a while now. 50 to 75% of carefully selected patients report at least 50% pain reduction with spinal cord stimulators. The key thing here is, I think this 50%, if you look at the studies, the 50% more refers to the classic older systems. Modern systems with higher frequency stimulation, that number is closer to 75% effectiveness and at least 50% pain reduction. It is most effective for radicular and neuropathic pain again. So better at that than the back pain. And again, there's the high frequency stimulators, which I use almost exclusively. They show superior results for certain pain types and are better than the classic systems. There was a recent Cochrane Review study, which is a good journal article, which recommended that spinal cord stimulators should not be used unless outside of investigational purposes. There was a big problem with that study. They used the older systems that weren't using high frequency or some of these other new technologically advanced systems where we're finding more effectiveness. So this is a respected database for journal articles. I mean, it was a very flawed study and it was a very strong statement and didn't look at some of these systems that have actually been out for years now. So I had a real problem with that. Yes, I mean, I agree. I don't use the older systems anymore. I don't think many people do. But yeah, it was a flawed study. It's something to keep in mind if you come across that. And multifidus stimulation, this is a new technology now. The multifidus is a core stabilizing muscle that runs up and down the side of the spine there. And what this is a restorative stimulation. This stimulator provides electrical stimulation to the nerve that activates this muscle. Another way to think of it is you're exercising the muscle without exercising. So, with this treatment, you have the implant, the system, they often want you laying down and the system works and stimulates the muscle and you're working out, strengthening that muscle. The data shows 65% reduction in pain and disability at 4 years. So very durable, and that's 65% is a big number. Now, the thing here is this is new. So that is all industry data. There are some significant critiques of the data. I am not 100% sold on this. I myself have gone through the training for it. So I could do it if I wanted to. I'm not quite there where I've thought it's something I want to move forward on yet. We're learning more about it, but it is very interesting and certainly could be a very, very successful treatment in the future. And the key thing here is when we compare it to classic spinal cord stimulation, it addresses the underlying instability, the micro instability from having these weak muscles, rather than masking the pain, which is essentially what the spinal cord stimulator does. And so those are a lot of the treatments. And what we want to do is really start with the lowest risk approach and progress as needed. So first line, you're going to modify your activity, heat, ice, then physical therapy, exercise. Again, meditation, breath work, should do it. Classic medications over the counter, prescription medications potentially. Then you kind of get into the minimally invasive procedures such as injections, therapeutic injections, blocks. And then if you can identify a pain generator and none of those other interventions are working, you can get into more advanced interventions such as ablations or stimulators. And in that smaller subset of patients for back pain, potentially surgery. And so, the patients come into my office, this is really a shared decision-making thing. It's not coming to my office with an MRI. You had back pain. Doc, how do you make me better? Well, I want to find out what your preference is. I want to find out what your values are. We got to discuss realistic expectations because back pain is tough to treat. So we'll talk about some benefits and risks. And one thing here, which I think is important, is we want to focus on function rather than pain elimination when it comes to back pain. If your back is 70 years old, the likelihood that you're going to be pain-free or eliminate your pain is probably low. Yes, we hope we make a big dent in it. But if we want to focus on your goals, I want to play with my grandkids. I want to carry groceries from the car to the house. I want to be able to take 2 flights of stairs. Those are very good goals. How do you get there? Because those are the things in life that'll make you happy. Not necessarily, I just want my pain to be 50% better. Yeah, that's important, but we want to get you to your goals that makes life satisfying. And so, key takeaways here: back pain is often multifactorial. Different types of pain are involved, so it does require multimodal treatment. Address both the physical and emotional components. We want to prioritize sleep, function, quality of life. We're going to start with conservative approaches. I want everybody with chronic pain, think about mind-body techniques. And then, the thing to keep in mind here is surgery is appropriate really for a significantly smaller subset of patients. And there are technologies that offer new options for resistant cases. And that's my talk.
Thank you so much. We are now going to transition into our Q&A session. If you have not already, you may submit your questions using the Q&A chat feature near the bottom of your screen. And if it's all right, I'll go ahead and get started with those questions. All right, first one looks like it's referring to a specific slide that you had shared previously. It says that CBT reduces pain severity by 20 to 30%. Was that across the board in the study or only a percentage of the people who participated in the study?
Can you repeat the question one more time? Apologize.
Of course, I'm sorry. It says CBT reduces pain severity by 20 to 30%. Was that across the board in the study or only a percentage of the people who participated in the study?
That was the people who participated in the CBT insomnia arm.
Thank you. Next question is, and we've actually gotten this question a couple of times via email and now here in the chat, are there any back and neck pain that respond well to chiropractic care?
Yeah, that's a very common question. Yes and no. I'm not going to talk folks out of chiropractic work. There are people who get good benefit from it. Most commonly, what I find is that people say they get better for a couple of days to a few weeks. And if that's worth it to them, by all means, go for it. If you have stenosis, which might be significant, a lot of neck pain, or I'm sorry, arm pain, leg pain, I'm concerned about nerve compromise, I will recommend against some of the higher velocity, the quick movements, and try and focus on more gentle mobilizing techniques. I mean, there are risks to it. It's not risk-free. Certainly with the neck, you have an important artery that goes through the bones of the neck. And you hear about rare issues with chiropractic work or other manipulations where folks can get injury to that artery and have strokes. Again, that is rare. But again, I'm not, most folks, I think if you're getting benefit from it, great. I don't know if there's anything specific that I would recommend in terms of types of chiropractic work.
Thank you. Next question is, are there certain movements you recommend avoiding for aging spine with arthritis?
Great question. This is very, very patient specific. If it hurts, there's a healthy hurt when you're getting into reconditioning. There is a hurt that, maybe a different activity, a different way to work out that muscle, mobilize that joint should be better. So again, this is where physical therapy, working with a trainer, at least for a period of time till you educate yourself on your body, can be of great benefit here. So everybody is going to be different. again, if you got to find the difference between a little bit of pain due to reconditioning versus bad joint pain if you hold yourself in a certain position for a period of time where you want to stabilize around that joint, you just should find a different activity for that. So, but it's very patient specific here, and that's where therapy and other guided exercise programs can be very useful.
Next question is scoliosis a condition you treat?
So I will treat some scoliosis. I do not treat adolescent scoliosis. I will treat adult degenerative scoliosis. However, if the patient has what we call a sharp angular deformity or a really long segment scoliosis, where we're talking about screws from the upper thoracic spine down to the pelvis, I will often refer those out. I'm often always happy to see patients at first to discuss it. And if it's something I'm comfortable with, I'll discuss it further. Or, if it's something I think is better seen at a tertiary center, for example, I'll refer patients commonly to Chicago or Ann Arbor. I'll let you know. But so I treat some, just not adolescent.
Thank you. Next one is how much experience or knowledge do you have about dry needling and medical acupuncture as a treatment?
Yeah. Uh, yeah, I think they can be of great benefit. Again, it's one of those things you never know till you try. I think in the acute phase, it can be effective. Probably also in the chronic pain also. I can't speak to the specific data on it, but there are people who really get a lot of relief with it. And again, we're talking about multimodal treatments here. So yeah, I think it can be a great thing, and certainly worth trying. And if you don't get response, I mean, I'm not one to spin wheels and recommend keep doing it. So I'd find another solution.
Next one is what are your thoughts about activities that would be most beneficial after PT is over? Then they've listed some examples of yoga, Pilates, general weightlifting, or resistance training.
Yeah. I believe in it all. So I believe as a spine surgeon, a balanced spine, a mobile spine, and I also strongly believe in strength and conditioning, even lifting heavy weights. I think that's important. Um, Pilates, yoga, and a combination of heavy resistance training, I think, is huge. I'm not going to talk anybody out of CrossFit. I think the key is if you have to have good form and technique, not get too caught up in the competition aspect of some of those things where you push things and your form gives way. But I think, Olympic lifts, some of these really heavy things are absolutely important. Now, going back to your question, the key is what are you going to stick with, right? When people ask me, well, what's the best thing? I know what I like to do, but if you don't like it, you're not going to stick with it. So find what you like, have some resistance training in there, have some mobility, core strengthening stuff in there. And if you focus on those things and finding a program that works for you, I think that'll give you the greatest success. And the thing here is, start small. Start small. If you set your goal too high to say, I'm going to do 5 workouts a week that are an hour long, and you don't hit that goal, that's a pretty lofty goal, then you're going to feel bad about yourself. You didn't hit your goal. Give yourself some flexibility, start smaller and work into that. So I usually say find something you like that interests you, work with a trainer for a little bit to get some good form, and start at least 20 minutes 4 times a week. 20 minutes 4 times a week is an easier goal, and you build from there as you gain confidence.
All right, we have a couple of questions related to massage therapy and how that helps back pain or could help back pain.
Yeah, massage therapy, it's one of those things. If it makes you feel better, I don't see any problem. Some of the deep tissue stuff, freeing up some of the myofascial tension. I don't know if there is great data numbers on it. If there is, I don't know what that is. Again, I think it can be of great benefit, and certainly working on some of the deeper tissue stuff to gain some mobility back. And if it makes your pain feel better, great.
Thank you. Next one is, do tall people have more back issues such as spinal stenosis?
You know, the tall people do have issues. I mean, there's the mechanical stress of being taller. You're dealing with more gravity. I don't know that they have more stenosis. They certainly are set up for some set of folks have laxity issues and hypermobility issues, and then you can get what we call small fiber peripheral neuropathies from the hypermobility. I don't know if there's really definitive data to say that there's worse overall just back pain due to taller folks. I think it just goes back to you really need to look at your individual spinal alignment and just which is more important.
Our next question is there a role for OMT in improving back pain?
Yeah, absolutely. Again, it kind of points back to restrictions. You want to release some of these restrictions so you can effectively build spinal balance, effectively work on your posture, uh, loosen up some of these tight, painful, contracted tissues. Um, I don't do OMT, so specifically, so there might be some newer advances and thought processes and on how effectively they can treat back pain, and I think that's a great discussion. And I do recommend OMT consultation for not a small amount of patients.
I know you covered a few of these, but what lifestyle modifications would you recommend to improve back pain?
Yeah. So if we're talking about acute back pain, you probably don't want to go to the gym. Um, you might probably want to walk a little bit if you can effectively, unless it's so severe. Um, most acute back pain with time, activity modification will ease within about 6 to 8 weeks. And so when that eases up, you want to get back into finding out what was the cause of that imbalance and work on that reconditioning. Chronic back pain, in terms of modifications, again, this kind of goes back to everybody's going to be a little bit different. Do you have set joint pain? Do you have discogenic pain? Um, do you have myofascial pain? And they all require different treatments. And so there's not really a blanket statement here. If you have mechanical instability pain, if you have facet joint pain, you maybe want to, especially with facet joint pain, avoid things where you extend and it shuts down. But you also want to be able to strengthen those muscles around there. So again, that kind of goes back to everybody's a little bit different. This is where guided therapy and exercises can be of great benefit here. And maybe I understand time resources can be difficult in doing full 6 weeks of therapy, but if you at least are able to be educated on what is best for you over a couple sessions, and then you continue that at home, that is, I think, usually quite a bit better than not doing any physical therapy sessions at all.
Thank you very much. This next one is asking if there is usually an age limit on surgery depending on the type of pain encountered.
No, nothing hard and fast. I mean, I've done a neck fusion in a patient in their mid 90s. I'll do single level fusions in their 80s. I'm not going to offer, unless absolute need of nerve compromise, loss of function, a bigger surgery unless I absolutely have to. So there's not a really hard and fast rule. Patient dependent, again, smaller procedures. We'll rarely do in the 80s and 90s with some hesitation. Try and get away without doing surgery. But if patients are really struggling, sometimes that makes the most sense.
All right, I think this might be our last question. It's very specific. What causes the sharp pain that hits right above the buttocks and also pain that occurs in the thigh?
Yeah. So, I mean, that is a specific question. And there are certain things, for example, going back to my talk, I'm thinking now, does this patient have sacroiliac pain? Do they have referred pain from a joint to the buttocks? Do they have some neuropathic pain underlying with radiation to the thigh? But at the same time, you can have sacroiliac pain, which causes pain to the thigh. You can have hip pathology, which localizes to the thigh. So the answer is when you say that, we're starting to key into certain things here, but without further discussion, without further exam, you're left with a few possibilities here. So there's not one thing that causes that. There are numerous things that cause that, and that's where careful exam and discussion becomes important.
All right, well, thank you so much. That is going to conclude our question and answer. Thank you so much, Dr. Lionel, for your presentation and insightful Q&A. And to all
Absolutely.
of our
Very happy to do this.
participants, yeah, thank you so much. And to all of our participants, thank you so much for joining us today. We hope everyone has a great rest of your day.